السلام عليكم دكتور حاتم.
Oh yeah, sorry, I was
بس كنت عايزة أتأكد إن الميكروفون بتاعي شغال.
how is the sound now? How is the sound now? Is it fine?
الصوت كويس.
الصوت كويس تمام.
أيوه
اوكي
أنت سامعني يا دكتور حاتم عشان
Yes.
إحنا قاعدين نشتغل من لابتوب واحد.
لا سامعكم كويس جدا.
تمام.
تمام. طيب this session is going to be about echo cases, okay? That like cases for the exam, okay? Usually these are the sort of cases you are going to encounter in the exam. And although I'm not gonna cover them all, like we are gonna give you hints and glimpses about how you describe the echo case. And I knew that in your exam you are gonna describe cardiac data in writing. So probably that needs a little bit of some technique. So you have to, because our exam here is code related. So they code for the echo. So we give them a paper, and this paper is showing like LV function, moderate, severe, and mild. It's code. So he or she has just picked up the codes relevant to the case and moves on. But now we are gonna write in text, so this is a bit different, okay? I think this might be easy or difficult. I can tell, like it's a bit different than the coding system. Now, let's take this first case. So what do you think about this case? So the first thing you have to describe is the view, I guess, and then the major abnormality. Okay. So who can take this one?
Okay, I can take it, Dr. Hatim.
Go ahead.
Okay, this thoracic echo showing long long axis view. The posterior hypokinetic area. Posterior with two-thirds posterior mitral leaflet.
Okay. So which wall is hypokinetic or akinetic?
The posterior wall. Oh, inferior.
Look at it again. Sorry, I'm gonna move it again. So
the septal wall.
Oh yes, you're right. Okay, so this one is the right side, RV, LV, anterior septum, posterior wall, posterior leaflet, anterior leaflet, aortic valve. And what is this here? What is this?
Precardial effusion.
No, it's not. It looks like precardial effusion, but it's not. So what it could be? This is fat. Okay.
This is epicardial fat.
Is it precardial or epicardial fat? Most likely this is pericardial fat, and the one below it, which is a small rim, is the epicardial fat. So this is epicardial fat, and this is pericardial fat. Okay, and I agree that it looks so much like precardial effusion. Like you could appreciate some granularity into it. So this is fat tissue, not fluid. Like you said, there is a kinetic anterior septum. So this is part of anterior wall MI. Great. This is the finding here. Good. You could also see that the left atrium is dilated, right? The left atrium is dilated. For, I don't know, the reason might be mitral regurgitation, might be diastolic dysfunction, anything. It's not showing here. But we have dilated left atrium, dilated LV, akinetic anterior septum. these are the findings, along with the description of the view itself, which you have stated correctly that this is prostate along axis. Good. And
Sorry,
now, yes,
sir.
yes,
Sorry.
تفضل.
Regarding the previous view, I just I have misfilling with the aortic leaflets. There is no abnormality. It is a normal like that, or it's a second. Just
It
asking
is
if
very hard to tell that it's thickened from this view. I perceive them as normal so far. لكن ممكن يكون في a little bit of mild thickening. But you know, these settle findings, it's good to know for the echocardiologist to pick up all the settle findings. But as far as the exam is concerned, try to focus on the major findings, okay? So the major findings here is the clear akinetic anterior septum. Probably the aortic valve itself needs a short axis to delineate the anatomy better and see exactly whether or not it's thickened and degenerative or, okay? But it's good to observe. It's good to observe anywhere. That's good, really good. Now, I
الصوت
think
شوية دكتور حاتم، الصوت شوية.
الصوت واطي. طيب دقيقة. Is it better now? Is it better now?
يس أحسن شوية.
طيب تمام. Okay, now what do you think about this case? This is the same case in short axis, right? So in the short axis, what level is this one? At what level is this short axis? A little bit up, okay? Because this is part of the mitral valve. This one you see here, this is part of the mitral valve. So this is actually not proper basal, but not proper mid cavity. It's in between. It's between the basal level and the mid level. Lakin I would say it's more basal. It's more basal. Once I see part of the mitral valve, this is basal. And here again, the anterior septum is showing, which is akinetic. Okay, akinetic anterior septum. Now, what is this?
apical.
Yes, this is apical. And what do you see in this apical, ya Fikri? How could you describe it in terms of motion abnormality? It is?
akinetic.
Yes, it is akinetic. How could you say it's akinetic or dyskinetic? Sorry?
Inward movement, inward motion of the myocardial muscle. If it is not going inward, inside, this means that is akinetic. The dyskinetic, it will go outside, to the out.
Aywa, yes, exactly. So akinetic means you have no appreciable thickening and contraction. Okay. Now dyskinesia is a paradoxical motion. Yani in systole it bulges out, and in diastole it goes in. So that means that you have to stop the view and go frame by frame and see during systole, when it comes in here, it gets wider in systole, and when you go in diastole, it gets narrower. Okay, so this is paradoxical, because in systole the cavity gets narrow and it widens in diastole. It's dyskinetic when the opposite is taking place. So to define that the apex is dyskinetic, you have to stop the motion and go frame by frame. Okay, but this is akinetic. Now, what do you see here? You also describe the view and the abnormality. Is the video clear or it's not?
It is very clear.
Okay, Dr. Hatim.
Go
It
ahead.
is.
Dr. Yasin.
Okay. Unfortunately, there's not a little bit delay for me, but now I see it well. So this is apical 4-chamber view.
Okay.
The abnormality I see there is looks thrombus in the apex
Okay.
of the left ventricle.
You think this one, huh?
Yeah, this side. Look, this thrombus is there in the apex. And I think it is well-formed thrombus. And also there looks a spontaneous echo contrast near to the thrombus.
Okay.
And the left atrium, I not measured, but it looks dilated because it looks bigger than the right one.
Okay.
So
And what do
this
you
is
think
not like
about the
The
regional
left
wall motion?
atrial itself, it has an apical akinesia, and it is ballooning and dilated the apical side.
yes.
Okay.
So most likely this patient having myocardial infarction in the LAD territory.
Oh, great, great. You've got, look at, now I think the majority of your description is right. This is the lateral wall. This is the lateral wall, which is contracting, right? Now look at the inferior septum. Inferior septum is not contracting. Maybe from the middle downward it's not contracting. At the base it might be contracting. So I have to mention that I have akinetic mid-inferior septum. Akinetic mid-inferior septum, okay? And the apex entirely is akinetic or probably dyskinetic. Okay?
Yes.
So yes, so this is it. Now this one here, you cannot be, yeah, it's good, it's so good that you suspect thrombus whenever you see something like this, but I think if you say this is a thrombus categorically, you might not be right, but thrombus cannot be ruled out, and you need further view with focused view on the apex, and you might also need to do contrast echo. Okay, so whenever you suspect a thrombus like this, you cannot diagnose it just based on this image. You need further orientation and better delineation of the apex to see if this is an actual thrombus or just trabeculation. And if that fails to show you the diagnosis, you might even give contrast, okay, like son of view, definitive contrast. You have to know that there are echo contrast agents that can be injected to opacify the LV cavity, and you can see the thrombus as a filling defect, and no longer you have any confusion about the diagnosis. Okay, so this is
I have a
important.
question.
Yes, go ahead.
Is there any difference between terminology clot or thrombus?
No, for me no. Thrombus clot is the same. LV thrombus is more of probably of the commonly used and probably the right term to say it's a thrombus rather than a clot. But if you say a clot, I wouldn't say it's wrong, no, at all.
Okay. Okay. And the management, can I use NOAC instead of warfarin?
So NOAC, as per the guidelines, is not indicated for LV apical thrombus. But there are some studies, including studies I have been the lead investigator in. We have used River-Expand for LV apical thrombus, and in the group of, or in the patient sample, we found that within few weeks the thrombus disappears. So far it's off-label. We are using it in some patients in whom warfarin is problematic, but we have to secure a special consent because it's off-label use. Off-label use. NOAC so far are indicated for non-valvular AF, period. All other indications are off-label. Okay.
Thank you, Dr. Hatim.
Now, what do you see here?
Sorry, sir, the image is not clear. It is
Clear. Maybe I will Uh-huh. Is
Okay.
it better?
It is clear.
Okay. Uh-huh. What do you see?
It is an apical four-chamber view with color and without color,
Very good.
showing aneurysmal apex.
Very good. Very good. I think that's the full description of it. Now, when you have like the same image duplicated with and without color, which button in the echo are you gonna press on? Color compare, right? There is a special button called color compare. When you press on it, you will have the same image side by side, one with, one without color. So you could describe this one as apical four-chamber color compare. Okay? Yes. And like you stated correctly, this is aneurysmal apex, and this is not dyskinetic. You see, we have said that the dyskinetic means paradoxical movement of the apex, but that one is aneurysmal apex. What's the difference? The aneurysmal is thinned out, like you see here. It is thinned out and persistently bulging out, and you could appreciate that there is a configuration between the normal walls contracting and the hinge point of the aneurysm. You know, the hinge point from where the aneurysm starts, you can define it here, and there is a persistent bulging out and thinning out of the apex. So this is true aneurysm. This is apical aneurysm. Any description short of this is not precise. This is a clear aneurysmal apex. It's not dyskinetic and it's not akinetic. So if you say akinetic apex, I don't like it. If you say dyskinetic apex, I will not like it. This is aneurysmal apex. Okay? Good. Now, what do we see here? Uh-huh.
Please mute some.
Okay.
Hatim,
So, yes? Okay, it's not moving. Okay, just a moment. Okay. So what do you think about it now?
It's an apical two-chamber view.
Yes, very good. Apical two-chamber view. That's absolutely right.
Oh.
Uh-huh. What else?
I think there is a rupture chordae.
Uh-huh.
Posterior chordal rupture.
Chordal rupture. Yeah, the mitral valve is a bit crowded and there is some laxity of the cord here, but there is no clear rupture cord I could see here. But try to focus on the LV wall motion itself, anterior and inferior.
Inferior. Okay.
Yes, exactly. You are so right. Now, the apical two-chamber shows two walls: the anterior wall
Anterior and inferior.
and the inferior wall. So if you compare the anterior wall with the inferior wall, you could appreciate that the inferior wall is hypokinetic or actually akinetic. There is no actual thickening. I might accept hypokinesis here. And the other thing is that, look at this one here. You appreciate an echo density, right? So please, whoever not speaking to me. Now, this one here is echo density or hyperechoic texture. This hypoechoic texture indicates subendocardial scarring, because you see the endocardium is here and this is subendocardial. So this is subendocardial scarring. So this is akinesis of the inferior wall with subendocardial scarring. The anterior wall also looks hypokinetic to me. Don't you agree with that? This wall
Yes.
is also hypokinetic along with the apex. So there is
Yes.
hypokinesis here.
Global
More
hypokinesis,
hypokinesis.
yes.
Yes, exactly. Now, what is this? Okay. Again, just I want to show you something here. This one, this part is the epicardial fat, and the one above is the precardial fat. Okay. So again, this is parasternal long axis. You see the mitral valve, anterior septum, posterior wall. What it is striking here is the akinetic posterior wall. You see the posterior wall here is akinetic. It's not contracting like the opposing wall. So this is akinetic posterior wall. So I brought this example to show you the akinesis of the posterior wall and how it looks like. Okay. Now, this is again akinetic posterior wall, but with additional abnormality, which is
Aneurysmal also.
exactly, and this aneurysmal posterior wall might even be rupture, might even be false aneurysm. That's why we gave contrast to this patient to make sure that this wall is not ruptured, because you see the geometry is supposed to be a circle and a donut, but the posterior wall is bulging so much outside. So if this is a true rupture or it's just aneurysmal, that's why we talk about false aneurysm and true aneurysm. You know, the true aneurysm is just the bulging of the wall outside, but the false aneurysm is the rupture of the wall and leaking outside, extravasation, and the formation of some sort of pericardium and hematoma around the wall. So we suspected rupture here, but by contrast, it turns out to be just a true aneurysm. So the posterior wall has true aneurysm without rupture. Now, this is apical 4. طبعا usually the views, we try in the exam to select the best views, but sometimes we select some challenging views like this just for further to add a flavor of difficulty. But usually the examiners are more into easier and obvious and clean, crispy views rather than this one. But this view again is an apical 4-chamber view, right? But there is foreshortening of the left atrium. That's why you don't see much of the left atrium. And the abnormality here belongs to this wall. You see this wall? This wall is the lateral wall. This is the lateral wall. This is the inferior septum, and this is the apex. The lateral wall shows no contractility, and in fact, it shows ecodensity. And again, this is scarring of the lateral wall. So this is akinetic lateral wall with evidence of scarring. Okay? So this is how you describe this image. Now, anybody can take this. So the view comes from where? From which window?
Apical 3-chamber.
Yes, this is apical 3-chamber view, right? So we see the left atrium, the mitral valve, the LV here, the aorta and the aortic root, and part of the right ventricle. Any abnormality?
Yes.
Which is?
the apex is so relatively hypokinetic,
Okay.
and even the inferior wall
Okay.
with
Good.
the dilated chamber
Uh-huh.
most probably the patient has cerebral disease.
Okay. Good. So you appreciated hypokinesia in different segments. Yeah, that is completely right. طبعا it's unfair to tell exactly the I mean the conclusion about the regional wall motion abnormalities from a single orientation like this one. Like you can have an impression. Now this anterior septum, this is the apex, this is the posterior wall. It is hypokinetic here, it's hypokinetic here, and also the posterior wall is hypokinetic. So this is more or less global hypokinesis. This is more or less global hypokinesis. Okay? Lakin I might say, it's not right from a single view to tell exactly whether it's global or regional, because you need to see all the segments in the short axis to tell precisely is it global or regional. Lakin from this image, it's more or less global hypokinesis. طبعا you appreciate that the LV is dilated, and unfortunately in the exam you might not have the luxury to measure the size precisely, but your impression is that the LV is dilated. It's important to mention the dilatation of the left ventricle. So the left ventricle is dilated by eyeballing, and you also have severe LV systolic dysfunction, because here the ejection fraction is something between 30, lesser than 35 here, okay, and you have also dilated left atrium, okay, dilated left atrium. So when you describe this image, you describe it in terms of which view, and the chamber status in terms of size and function. And when you go for the function, you better also categorize the function quantitatively. So when you say there is LV systolic dysfunction, you have to say, is it mild, moderate, or severe? Okay, like this one here, it tends to be severe. Severe LV systolic dysfunction, global hypokinesis, dilated left atrium and left ventricle. Aha. Now, what do you see here?
This is black
Huh? Sorry, again?
view, parasternal
Sorry.
long axis view,
Parasternal long axis, okay.
showing
Mm-hmm.
there is normal left atrium
Okay.
with all sorts of LVH,
Okay.
mainly the septum.
Okay.
Okay, there is anterior motion of the anterior mitral leaflet
Mm-hmm.
without obstruction.
Without obstruction. Then, the view, yes. The LVH is quite likely here. Okay. And now SAM, not really. Yes, the mitral valve is a bit thickened, but no SAM. Yani SAM, you will see it after the mitral valve closes, then it kinks towards the septum after it closes. When the LV is contracting, you would see that the anterior leaflet jumps toward the LVOT, hitting the septum. So we don't see that. So there is no SAM. Like, I want you to compare this anterior septum to this posterior wall in terms of contractility. Are they the same? Are they the same?
No, it's kinetic.
So they are not the same, right? So what's the abnormality? The posterior wall is what? Look at it. Yani, is there any thickening in the posterior wall?
Yes.
Apart from the base, because the base moves with the cardiac skeleton. Take it from here downward. Do you appreciate any thickening here? The thickening is like this one.
No.
See, thickening. No thickening. So this is
No thickening,
akinetic.
yes.
Yes. This is akinetic posterior wall. This is akinetic
Even-
posterior wall again. Okay. So this is akinetic posterior wall. By the way, طبعا the description or picking up the abnormality in the segmental wall and I mean the wall motion abnormality isn't really easy, and it needs experience and can be missed a lot if you don't focus well enough. So in this case, that's why the first views in this session I brought them all relating to the regional wall motion abnormalities, because I know this is one of the toughest part of the echo. So I want you to get familiar with the akinesis of the wall, like this one. So it's not the absence of movement. Akinesis is not the absence of movement. It's the absence of thickening, because at any particular time, any segment in the heart is moving by tethering movement, because this part is connected to the rest of the heart, so there will be traction movement. So you will see it moving. So you have to focus so well in the inward movement. Is there any inward movement? Is there any thickening in this direction, or just traction going from side to side, which is passive movement and doesn't count? So this is akinetic posterior wall, because I appreciate no thickening, no inward movement, but I could appreciate the traction movement from side to side. Okay, so this is akinetic posterior wall. And now this is a very bad image in terms of quality, but this is apical 3, and you see here the anterior septum, the apex, and the posterior wall. Now the posterior wall, if you see the endocardial border, you don't see any thickening. Again, this is akinetic posterior wall, akinetic posterior wall. And not only akinetic, but it is thinned out. If you compare this one back here, this one is akinetic, but it's not thinned out. Still the thickness is preserved, but when you see here, it is echodense and thinned out, and this indicates scarring and non-viability. Okay. The other thing that you could observe in this echo, something that has to do with the mitral valve. What is abnormal in the mitral valve here?
Prolapse.
Of what?
Anterior. Reflex.
Yes. So there is anterior leaflet prolapse. What about the posterior? This one.
Tethering and retracted.
Thank you so much. So this prolapse in the anterior leaflet is not true prolapse. It is relative prolapse. Why it's relative? Because you see it prolapsing because the posterior leaflet is tethered and tracted downward. So the traction and the tethering of the posterior leaflet gives an impression of anterior leaflet prolapse. That's why when you call it prolapse, call it relative prolapse. So this patient is having ischemic mitral valve and ischemic mitral regurgitation. This posterior leaflet is tethered because the posterior the papillary muscle is adherent to this wall, which is scarred and akinetic. That's why the corresponding leaflet is not moving well, and it is tethered downward or apically. Okay, so we will find that this patient is having MR, and the direction of the mitral regurgitation will be posterior towards the tracted, towards the tethered leaflet here. هيكون posteriorly directed. You remember I told you last time the trap rule, towards restriction, away from prolapse. Towards restriction, if the posterior leaflet is restricted, the MR direction will be posterior. Okay, and when you have prolapse anatomy, the direction of the jet will be away from the prolapse. So if you have prolapse in the anterior, it will be posteriorly directed jet and vice versa. Okay, so this is posterior infarcted infarcted posterior wall with tethering of the posterior leaflet, indicating ischemic MR, the quantity of which needs to be evaluated. لأنه هنا I am not giving you any color to decide about how severe. Like in this patient, it was severe mitral regurgitation. Okay, that's why you have to describe the anatomy of the mitral valve. If you miss the anatomy of the mitral valve and you describe the wall and the view, you are having -1 out of the total. Okay. Now, what is this? Where are we here? This is apex, right? Apex. So is it normally contracting, hypokinetic, dyskinetic, akinetic, or aneurysmal?
Generally hypokinetic with dyskinesia in the anterior septum, apical septum. Sorry.
I will take the first part. It's hypokinetic, because if you say hypokinetic, you cannot say hypo and dyskinetic together. لكن sometimes بيكون في يعني honestly speaking مرات بيكون في جزء hypo, جزء بيكون في dyskinetic. لكن in the apex in particular, the apex goes together. So it's either all hypo or all dyskinetic. Okay, so this is all hypokinetic. There is still thickening, but this thickening is not as strong as normal. So this is hypokinetic apex. Okay, hypokinetic apex. Now this one, compare it to this one, this is normally contracting apex. Okay, normally contracting apex. طيب, what do we see here? You have to tell me that this is parasternal short axis LV view at the basal level. So this is important part of your description. So parasternal short axis, LV short axis at the basal level, because we are still seeing what? Mitral valve, and we are still short of the papillary muscle. This is the mitral valve, so we are at the basal level. Then describe the abnormality. The abnormality is what? Compare the contractility here with the contractility here. Are they the same?
No.
Not the same. Yes, it is hypo. Where is the hypokinesis? This segment and this segment. What is this segment? What is this segment? Sorry? Yes, you are right. What is it?
Inferior and inferior lateral.
Yes, this is inferolateral or posterior. This is lateral. This is anterior. This is anterior septum, inferior septum, and inferior wall. So we have 6 segments here, 6 segments at the mid cavity, and 4 segments at the apex, and the apical cap, total of 17 segments. Okay, so when you describe it here, you will say that I have hypokinetic basal inferolateral segment and basal inferior segment. Okay, basal inferolateral and basal inferior wall or inferior segments. That's what we see. And they are hypokinetic because we are appreciating a little bit of contractility, but not as good as anteriorly. So it's hypokinetic here, but not akinetic yet. Okay? Now, this is foreshortening. Unfortunately, the apex is foreshortened. But if you compare this is apical four-chamber, there is foreshortening of the apex, there is foreshortening of the RV. So when you see the RV like this, that it does not necessarily mean the RV is compressed from outside or stuff like that. It's simply foreshortened, and you have to do some manipulation in your proposition to make it better. But if you compare the wall motion here, you will see that the inferior septum and the apex and the lateral wall. Where is the problem now? Which wall is abnormal?
The lateral wall.
Yes, so this is akinetic lateral wall. The lateral wall is akinetic. And the lateral wall belongs to which artery?
L6.
Okay.
Sir, could be the diagonal sometimes. Yes, okay, good.
Yes.
Now, again, this is apical four-chamber, and when you see here the lateral wall is akinetic, the lateral wall, akinetic, and if you track it down to the apex, you will see that there is some bulging here in the apex, which need to be, and focused on. What are we dealing with here in the apex? We don't know, but this view is not so helpful. Lakin what is helpful here is that I see the akinesis of the lateral wall. And compare it here, it's contracting, apex is contracting. When it comes to the posterior wall, lateral wall, again, it's not contracting. Now, this is toward the apex, and again, it's hypokinetic apex. Some people describe it as akinetic when the contractility is very weak. They can say, so the difference between akinesis and hypokinesis is a matter of sensitive eyeballing, if you describe this one as akinetic, I wouldn't, give it wrong. But if you say severely hypokinetic, I also wouldn't take it as wrong. It is severely hypokinetic or akinetic, yeah. Okay, this is it. Now, this is again, we have to describe it as I told you before, apical three-chamber color compare, because you have color on the right side. And the problem is in the posterior wall, but it's not showing well. But what is showing here is this echo density. Whenever you see echo density, meaning you have evidence of scarring in this wall. So remember, the echo density in the wall means scarring in the wall, and most likely the wall will be either hypokinetic or akinetic. Okay. Now this one here is apical two-chamber, and we are seeing the anterior wall and inferior wall. Anterior wall, inferior wall, and the apex. So what abnormality are we seeing here? What abnormality?
There.
Guess, just guess.
Inferior.
Yes. Oh, thank you so much. This is inferior. عشان كده يا اخوانا انا بقول لكم يعني regionality is really tough. It's really tough. You have to be so sensitive. يعني الآن انت if you look quickly at this image, you may say ما في حاجة. أو ربما it looks like global problem. No, it's not global. Look at this inferior wall. Is it moving? Yes, it's definitely moving. Is it contracting? No, it's not contracting. Because if you focus more, it's just moving passively, but there is no actual thickening, not actual thickening like in the anterior wall. So this is akinetic inferior wall. akinetic inferior wall. Okay, so this belongs to the RCA territory.
What about the bulging in the apex? There's something strange.
Here, no, the contractility in the apex is fine here, but if you see the base posterior and the the basal inferior and the mid inferior are not thickening, meaning akinetic. The anterior wall is thickening, so it's contracting, but no contractility. Okay, so try to mute, please. Mute. Okay. Now, what do you see here? What do we see here? Okay, I'm giving you the same patient and in parasternal long axis and in apical 4 chamber. So, what do you see?
Thinning out of the septum.
The left optical septum.
Sorry, again? If you can raise your voice.
The left one is the parasternal long axis showing dilated LV and LA.
Okay.
With the mitral valve looks thick.
Okay.
There is hypokinesia mainly in the posterior wall.
Okay.
Type, even the RVOT, it looks to some extent dilated.
Okay.
Regarding the second one, right side, the parasternal long axis.
Okay.
It is apical 4 chamber
Very
view,
good.
showing dilated LV with the hypokinesia in the apical and to some extent in the lateral. With
to some extent, the lateral. Okay.
With the thickening of the mitral valve.
Okay, so I think you have get it all. With the small correction we are gonna go through. So this is parasternal long axis, and this is apical 4. This is dilated LV, yes. And we said that in your description you have to quantify the LV systolic dysfunction. How bad this LV systolic dysfunction? Is it mildly impaired, moderately, or severely?
Severely impaired.
If I ask you to guess the ejection fraction in this patient, how much you will give?
I will give less than 40%.
Okay, and you will
approximately
give 35, 30, like, okay, yes. So that's reasonable estimation. So this is severely or moderately, severely, and I will go with
20.
Severely, yeah. Severely impaired LV function, exactly. Now, look at the anterior septum. It is contracting, but not normally. The posterior contracting, but not normally. The inferior septum contracting, but not normally. The lateral wall contracting, but not normally. So, when you compare them all together, they are hypokinetic segments. So this is global hypokinesis. It's not segmental, because you appreciate the same amount of hypokinesia uniformly across many segments. So when you see the same hypokinesia in many segments, that is global hypokinesis. So this is a case of non-ischemic cardiomyopathy with severe global hypokinesis. طبعا don't ever say non-ischemic cardiomyopathy in the exam حتى لو لقيته global. ليه؟ لأنه it might be ischemic. أي نعم, yes, we agree that the ischemic cardiomyopathy usually manifest as global, as regional, لكنه sometimes it can be global. فدon't say, or you cannot conclude إنه this is ischemic versus non-ischemic based on being global or regional. لكن most likely if it's global it's non-ischemic, if it's regional it's ischemic. Yeah, we agree. لكن don't write it in the exam. Okay? But this is global hypokinesis, severe LV systolic dysfunction, and dilated LV. Okay? Good. Now, this is of the same patient, by the way. This cut is at the level of the papillary muscle, you see here at the mid cavity, and you could see the global hypokinesis because the segments are equally hypokinetic, so this is global hypokinesis. Now, what do you see here? Apical two-chamber. What else? Yes, go ahead.
Apical two-chamber.
Very good.
And showing hyperkinetic, the lower part of the lateral and inferior.
Very good. Okay.
Okay. To the apical part.
Okay.
Dilated aneurysmal apex.
Okay, very good. So
mid
what?
to the
You've got from the mid downward we have what?
Hypokinesis.
Dyskinesis, actually. If you observe more and you focus more attentively, you see it gets dilated a little bit during systole. So when the base is contracting, this is a little bit bulging out. And when it's relaxing, it comes back. So this is dyskinetic, dyskinetic apex, like including even part of the mid segments. Any guess? Any guess?
Yes, Takotsubo most likely.
ممكن يكون Takotsubo. Exactly. Now, what is the grade of the diastolic dysfunction in this patient? You have EA and EA ratio is 1.5. You have E prime is 8.6. E over E prime is 11. So how could you describe this diastolic function?
Is grade 1 diastolic dysfunction with reverse ratio.
Yep. If it's grade 1, I would be expecting it to be EA like this. EA. So EA ratio is less than 1. But here EA ratio is 1.5.
Reverse.
So
this pseudo-normal.
Pseudo-normal.
Diastolic dysfunction. So we need to
you need
to
feather.
do other.
You need feather, right?
Yeah.
Pseudo-normal, I might say reasonable. Like, you know what? Whenever you have E over E prime, like this, E over E prime. Let's discuss E over E prime. You have more than 15 and less than 9 and in between. Okay? If it is less than 9, that is what? Normal. If it's more than 15, that is abnormal. And if in between, that's a gray area. Like you said, Dictora, correctly, you need to seek further measures to decide about the grade and the state of the diastolic function. So here it was 11, so it's falling in the gray area. So probably you need further metrics and measurement. Okay? So it might be pseudo-normal and it might be normal. Okay? It might be pseudo-normal or it might be normal because it's in the gray area. So you have to look further. Like if it's more than 15, it's abnormal. If it's less than 9, it's normal. Now look at this one here. You have E over A is 2.5, and you have E over E prime, which is 5. So that is normal. Okay, that is normal, because we said if it's E over E prime is less than 9, that is normal. If it's E over E prime more than 15, that's abnormal, and we need further search if it is in between. So this is 5, so this is normal. Now look at this one here.
Hatim?
Yes?
Hatim, معلش.
Sure.
What about E to A ratio? It is 2.5. Come with severe respiratory dysfunction.
Not necessarily.
If there is,
because yes,
okay.
I agree with you. I agree with you. Sometimes you can have even 3 and 3 plus, okay, and it is normal, because in athlete, young, healthy people, they have very high E and A, like this.
Oh, okay.
It looks like restrictive. That's why, to tell it apart, if this is abnormal or abnormal, you always have to take it into E over E prime. E over E prime is gonna tell you whether this is a healthy athlete person or abnormal. Okay?
Yes.
So it's,
okay.
yes, exactly. Now this one here is E over A ratio is less than 1. Less than 1. So this is what? Grade 1 diastolic dysfunction. You agree with that?
Yes.
Grade 1 diastolic dysfunction. سابقا كنا بنقول grade 1 diastolic dysfunction لما يكون الشكل A over A less than 1, we divide it into 2. If E over E prime is more than 15, we call it grade 1 A diastolic dysfunction. Grade 1A. Grade 1A. And if E over E prime is less than 15, we call it grade 1. بمعنى لما تكون more than 15 معناتها عندنا elevated LVEDP. That's why we have to distinguish it from when no elevated LVEDP. لأنه usually مع grade 1 you don't have elevated LVEDP. لكن لما تلاقي ال E over E prime more than 15, though it looks like grade 1, فبدوها مرات الديستنكشن بتاع grade 1A عشان يعطوا connotation إنها associated with LVEDP. لكن this is no longer in the guidelines. The guidelines is just describing it as grade 1 or mild LV diastolic dysfunction. Now, this one here is grade 1 from the mitral inflow. Now, look at here. What do you see here? I'm not giving you the mitral inflow. This is for a different patient. Just look at this one here. This is the mitral inflow and the E prime. Could you guess what diastolic dysfunction we have here?
The E is larger than the E prime.
Okay. Yes, I agree with you. If I take this one here, this is 60, and if I take this one here, it is 4. So 60 over 4 is what? 60
15.
over 4. Come 15. Okay, so 15, E over E prime is 15, and I also have what? This L hump, which is mid-diastolic flow. So this is extremely suggestive of grade 2 diastolic dysfunction. Grade 2 diastolic dysfunction. Okay, so when you see the mid-diastolic flow or the so-called L hump, and this indicates elevated LVEDP, because when you have high LVEDP, the valve keeps open even during diastole the mid diastole, because usually in mid diastole you have it like this. In mid diastole you don't have much of flow, but when the LA pressure is high because of high elevated LVEDP, the flow keeps going even in mid diastole. So they call it diastasis flow, because this stage of diastolic function is called diastasis phase. So when you have diastasis flow, that suggests grade 2 diastolic dysfunction. Okay, so remember the L hump. Okay, now this one is, you see this here, E, A,
Grade 4.
yes, and you see the E prime is so low, and
Yes,
E over
restricted.
E, yes, E
22.
over E prime is
22.
22. So which grade is this? Grade
4. Grade 4.
3 and 4. Severe risk.
exact 3/4.
Yes.
Okay, restrictive, both of which are restrictive. This is reversible, this is irreversible, but I don't know here is it reversible or not, so I will call it restrictive diastolic dysfunction grade 3/4. Okay,
Yes.
now what's the problem here? This one here, dilated LV, okay,
And dilated.
dilated left atrium, okay,
And the
Aortic valves heavily calcified.
yes. Heavily calcified aortic valve with limited excursion, so degenerative aortic valve. And what do you think about the LV function? Is it impaired?
yes.
Yes, impaired, at least moderately impaired LV systolic function, with a suspicion of severe aortic stenosis. But from the morphology, it is suggestive of severe aortic stenosis. Like, definitely you will need to have the gradients and all of that. Okay. Now, what is here? What do you see here?
Sam.
Yes, now this is SAM. طبعا unfortunately I cannot stop and scroll, لكن try to observe here in this part.
Yes.
When there is contraction, the valve closes and it moves to the septum. It hits the septum. Look at it again. Do you see it?
Yes.
Yes, okay. So this is SAM. And you look here, this part is below the valve. The valve is here. And this is below the valve. What do you see here? The color, what does it tell you? Flow acceleration in the LVOT. So when you see flow acceleration in the LVOT, that means you have sub-aortic stenosis created by the LVH and the SAM. Okay? So this is LVOT obstruction just by the color. It might not be severe, but you have to have the gradients for. Like, as per the color, there is LVOT flow acceleration suggestive of some degree of stenosis or obstruction of the LVOT. What else do you see? Posteriorly directed MR, which is significant posteriorly directed MR. And this is due to the SAM, because the SAM leads to anatomical distortion of the valve. So when the leaflet moves this way, there will be a coaptation problem and you will have a posteriorly directed MR like this one here. So this is a Hookham case with LV obstruction, with SAM, with eccentric severe MR. Now the M mode is shown here for a Hookham patient. What do you see in this M mode, or how would you describe it? The first thing, by the way, so as not to get lost in the M mode, the very first thing, go up.
Yes.
And see where the interrogation line is cutting through. It is cutting through the aortic valve.
Yes.
So this one here is the aortic valve. لأنه otherwise, if you don't see this one, you might think this is mitral valve. and you get lost. So look up, okay? Look up. So this is aortic valve. So why it looks abnormal like this? I know we are familiar that the normal mitral aortic valve looks like this. It's a rectangle. It opens and closes this way. So why now this is a mid-systolic notch? Mid-systolic notch. This is mid-systolic notch. This is how you describe it. Or mid-systolic closure of the aortic valve due to dynamic LVOT obstruction due to Hookham. Okay? So this is how you describe it. Mid-systolic notch or mid-systolic closure due to dynamic LVOT obstruction due to Hookham. Okay. Now, sorry? Okay. Now, this is a bit different because this is again we have... Yes?
I have a question regarding this.
Sure. Go ahead.
When I'm going to the valve,
I lost your voice.
صوت ما واضح يا سارة.
If I have
صوت بروح ويجي.
فكري إذا سمعت يا فكري كلمني لأنه أنا ما سامع.
أيوة كده تمام.
أيوة كده سامعين.
If I have a patient with the SAM, I'm going to change the valve. If a valve is a severe mitral valve,
okay,
I'm going for a septal myomectomy. Okay. I'm going to change the valve if it is severe mitral regurg due to SAM.
Okay, this is a very nice question. So what we do when a patient is elected for septal myomectomy, we assess the valve pre-operatively. Like usually, you cannot diagnose the reversibility of the MR prospectively. So what we do is we wait for the surgeon until he does this septal myomectomy, and then we come and do intra-operative TEE while the patient is still in the OR, and we assess the MR. So we expect that with the elimination of this part, the SAM will disappear, the valve will regain its integrity, and the MR will disappear. In this case, we call it a day. لكن إذا لقينا لسه الليفلت is abnormal and still there is MR, we advise the surgeon to repair or replace. Okay, so it depends on the intraoperative TEE. Okay?
Okay.
Did that answer your question, Sarah?
Yes, yes.
Okay.
Thank you.
Now, this is parasternal long axis, and you see there is LVH, and even the LVH is involving the RV as well. So there is RVH, there is LVH, and it tends to be significant LVH. But there is no SAM. It's only the thickening of the wall here as shown in the M mode. So this is concentric LVH. Maybe the patient is hypertensive and stuff like that. Now, what do we see here? Parasternal long axis. What else?
Parasternal long axis view showing a dilated aortic root.
Yes, 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 exactly. You're right. The aortic root is dilated. Okay. And what else? Here.
The Mixomytus mitral valve.
Exactly, exactly. So Mixomytus mitral valve and prolapse, and you see here in the M mode the prolapse is here. You see that prolapse?
Yes.
And during diastole, the valve is expected to behave like this. Okay.
M plus W.
Exactly. But when this is during systole. So that the systolic closure line is supposed to be like this. But when it goes down like this, sagging of the closure, that indicates prolapse in the M mode. So this is how you see the prolapse in the M mode, this way, okay, this way. Sometimes the prolapse is part. The M mode provides you with the great temporal resolution, as we said before. So you could even know when the prolapse is start, because here it is start mid diastole. It's here, right? So in the initial phase of diastole, there was no prolapse. The prolapse started mid. Exactly. But sometimes there is pan-systolic prolapse, and it becomes like this one. And they call it hammock. Hammock. You know the hammock؟ اللي هو في البيتش مثلا بيكون في شجرتين كده وعاملين لهم حاجة كده زي السرير في النص كده.
طحانية.
Exactly. When it becomes like that, that means pan-systolic prolapse and hammocking. Okay? So you could time the onset of the prolapse by the M mode, but it's very unlikely you time it from 2D. لأنه 2D is not as good as M mode in temporal resolution. Okay? طيب, now what do we see here? Sorry, stop some. Sorry. I don't know where it's going. So try to observe the behavior of the mitral valve. That is showing SAM so clearly. You see the SAM? طبعا you see the asymmetrical septal hypertrophy and the SAM. You see when the valve closes, it moves to the septum, closing the LVOT. Okay? So this is SAM. Now, what do we see in the M mode? What do we see here in the M mode? First of all, look here. Where it's cutting? Through the mitral valve. So this is mitral valve M mode. So what are we seeing there?
Also there is SAM.
Okay, there is SAM. لاحظ الآن, if you don't look here, you might expect this is what? It looks like aortic valve. That's why it's so important to correlate the M mode with the image above. So it's cutting through the mitral valve. So this is the mitral valve. So this is the mitral valve. And when it closes, it goes anterior. The anterior leaflet moves toward the septum. So this is SAM. This is SAM. This is SAM. So this is SAM by M mode. So you can see SAM by M mode better than you can see it by 2D, again for the same reason, which is the temporal resolution. Now, what do we see here? This is probably an easy one.
Peripheral long axis view.
Okay.
Dilated left atrium.
Okay, very good.
It's mitral stenosis.
Very good. Mitral stenosis, but I'm missing one thing you have to describe before mitral stenosis. The morphology of the mitral valve itself is rheumatic, yes. So
okay, rheumatic
mitral valve with mitral stenosis. طبعا it's not right to tell about the degree of stenosis based on only 2D. We have to have a lot of other parameters, but there is definitely some degree of mitral stenosis here given this anatomy. Okay, and whenever you see mitral stenosis rheumatic, look at the aorta because it might also show features of rheumatic rheumatic features. Okay, so look at the aorta. Now this is M mode of a rheumatic mitral valve with stenosis. This is how it looks like. طبعا no longer you are gonna see the M and W is tough. Instead, you are going to see it like this, and the anterior leaflet, the posterior leaflet, instead of opening up, it's moving anteriorly. So there is distortion of the excursion of the mitral valve, and you will see lots of echo and reverberation because of the calcification and thickening, as if you have a mass in the valve, but that's not a mass. This is the calcification with reverberation and shadow artifact. You see these shadow artifacts. These are shadow artifacts, and this magnification of calcium is due to the reverberation. Okay, so this is how you see the mitral, rheumatic mitral valve in M mode. Now, what do we see here? Okay, very good. So this is parasternal long axis zoomed on the aortic valve, and there is aortic regurgitation. Now this aortic regurgitation I would accept if you said this is severe. Okay. طبعا نحن في الكودينج سيستم لما تكون الامور is not so clear بنكتب moderate to severe, and most of the fellows will choose moderate to severe because they are not so sure. You can write it moderate to severe. لكن you will definitely, and it's good to tell me that you are gonna go for quantitative measure like vena contracta, and if it's more than 0.6 centimeter it indicates severe. Okay, حتى لو ال LVOT jet is more than 65% filling of the LVOT, this is also indicates severe. So if you look randomly at the jet here, it is probably something around 60 and 60 and more. Now this is M mode across the mitral valve in this patient with AR. Yes. And what you see here is, what do we see here? Sorry?
Fluttering of the anterior leaflet.
Fluttering. What else? Fluttering. Anything else?
B bump?
No. B bump is expected to be seen here in the AC shoulder.
Closure of the mitral
The
valve.
systolic closure of mitral valve, yes.
Closure of the mitral valve.
The valve is probably supposed to be like this, right? So it's prematurely
Closed.
Closed, okay? So we have fluttering and premature closure. Which one suggests severe aortic regurgitation? The fluttering or the premature closure, or both?
Both, and more on the premature closure.
Oh yes, you are so right. The premature closure is due to what?
The regurgitant blood.
Increase in the systolic volume.
EDB.
Yes. So Fikri thinks that the premature closure is due to the mechanical effect of the jet itself impeding the opening of the aortic valve, the mitral valve.
Plus the increase the
LVEDP, right?
Yes.
Yeah, exactly. It is basically due to high LVEDP and rapid equalization leading to premature closure. So it indicates severe aortic regurgitation indirectly, because you expect when you have severe AR to have high LVEDP, and that will lead to premature closure. So remember, premature closure is due to elevated LVEDP, not merely due to the encroachment of the regurgitation on this. But the flutter is due to the mechanical effect of the jet on the anterior leaflet. So the flutter is a mechanical effect, this one is a pressure effect, okay? So remember. Okay, now what do you see here?
The left,
yes,
there is a parasternal long axis view.
Very good.
Showing mass in the LA, which protrude to the aorta during diastole.
Very good.
With the dilated LV. The right one showing M-mode across the mitral valve, showing that during diastole there is a fullness.
Okay, exactly. Yes. So this is how a mass is filling in between the valve. Okay. So what's your diagnosis here?
Most probably myxoma.
Okay, good. Most probably myxoma. Don't shy away from saying it's most probably myxoma, but don't say this is myxoma. But say it's most probably myxoma, but don't leave it blank. Yeah, don't describe the mass and stop short of giving a diagnosis. But don't give a categorical diagnosis, meaning a single one that you are sure of, because we are not sure. Most likely myxoma, like it can be sarcoma, it can be, I don't know, it can be some other diagnosis. But most likely it is myxoma. So you describe it correctly, and it's good to describe the texture, and if there is calcification, you have to mention it. If there is echolucency, يعني sometimes you see the mass, first you describe, هل is it regular ولا irregular, okay? And then when you see some يعني black dots into it, that means echolucency. You don't have to say there is liquefaction or stuff like that, because liquefaction is a histopathology diagnosis. But in echo we say we find echolucent spots or echodense spot. By echodense we mean calcification, and by echolucence we suggest liquefaction. Okay, but we have to stick to the echo jargon, not the histopathology, because we don't know exactly. So you describe that this mass is irregular. You see, it's irregular, it's mobile, it's coming into the plane of the mitral valve, probably with obstructive effect, which needs to be clarified by gradients and colors and all of that. Now, there is echolucency, there is echodensities. طبعا are not showing in here, but if there are, you have to describe it. That will be a bonus in your description. Okay. Again, this is a mitral valve prolapse. Again, the same prolapse, and you see the prolapse is also showing here in the M mode. You know, it's late systolic prolapse, as you see here. Okay. Now I need some diagnosis here. Who can take this? Who can take it?
Okay, I can take it. This is long peristernal axis view, showing mildly dilated left atrium and also looks dilated left ventricle with the posterior mitral leaflet looks prolapsing.
Yes, prolapse of the posterior leaflet. طيب, prolapse is not wrong, لكن I need a more precise description.
The posterior leaflet also looks
you look here, you see that the posterior leaflet is coming so much into the left atrium with some tissue at the head of the leaflet. Yes, so this is rupture cord and this is flail. Yes, so you better describe it as flail. Flail is some extreme degree of prolapse. Okay, so it is essentially it's prolapse, lakin when we see a ruptured cord and the prolapse is so much into the left atrium, we call it flail. So like this one here, I love if you tell me it's flail. It's flail posterior leaflet. Okay, so here you expect the MR to be severe or moderate or mild?
Severe MR.
Severe. طبعا هنا if you write it is associated with severe MR, I'm gonna accept this for sure. لأنه the anatomy is in keeping with severe MR. And what if the direction of the jet is expected to be?
Anteriorly directed.
Anteriorly directed. So if you are going to examine this patient with stethoscope, you have to go anteriorly. You trace the radiation of the murmur anteriorly across the sternum up toward the aortic area. If you go toward the axilla, you are not going to find it. Okay? It doesn't go toward the axilla. It goes toward the axilla if it's central or posteriorly directed. But if it's anteriorly directed, it goes toward the aorta here. That's the aorta. So you put your stethoscope where the aorta is. So you go up. Okay? Good. So that's in clinical examination. Sometimes we ask them how you correlate this echo image with the clinical exam, and you adjust your clinical exam to pick the right signs from the right site, and they get lost. So remember, sometimes we do some mix. Now, what do you see here?
This is can I take it?
Yeah, sure.
This is long brachyther axis view showing dilated left atrium and the ventricle, and the mitral valve looks malcoacting, giving a view like secondary to giving a clue for mitral regurgitation and maybe due to dilated cardiomyopathy.
Very good, Ya Rabah. I think you have done most of it right. Okay. I like this malcoaptation description because the valve is clearly malcoapting. So this is called effaced valve, effaced. And the second degree after effacement is the coaptation gap. So there is no yet coaptation gap here, because when it closes without a clear gap. Okay, but it is so effaced because it's stretched out because of the annulus or because of the apical tethering of the posterior leaflet. And if you see, you compare the movement in the anterior and in the posterior, you will find that the posterior is not moving as much as the anterior leaflet. And that's because of what? Look here.
Hypokinetic posterior wall.
Akinetic posterior. So this is ischemic mitral regurgitation, because the posterior leaflet is pulled by the akinetic posterior wall apically, leading to this morphology, which is ischemic MR, and here it was severe ischemic mitral regurgitation. You are right that the LV is dilated, the LV is impaired moderately or severely. There are some degenerative changes in the aorta. There is RV impairment. Also, the RV is impaired. You see here. Okay. Now, what do you see here? This is the problem with zoomed in views. This is a zoom in view across the mitral and aortic valve with color compared. And you see that there is, exactly, go ahead.
The aortic valve thickened with jet of severe mild aortic regurgitation, and also the mitral valve is thickened with moderate mitral regurgitation.
Yes. You could say moderate or moderate to severe. You need further quantification. In this patient, it was severe. And by the way, this patient is the same. This one, it's the same patient. Okay, it's the same patient, but it's zoomed in. Look at the posterior wall. It's akinetic here. Look at the posterior leaflet. It's tethered and not moving well. The anterior is moving well. There is effacement and probably coaptation defect, and there is central jet of mitral regurgitation. Sometimes it's central, sometimes it tends to go more posteriorly, like we said. And the degenerative changes in the aortic valve we appreciated in the former slide is associated with aortic regurgitation. What do you call this image here? What do you call it?
color M mode, color
Color,
mode.
yes. This is color M mode across, you see here, across the aortic valve and left atrium, and it is showing flow acceleration here and here. This one is what? This part is what?
Diastolic.
So this is the AR and this is the MR, right? This is the AR and this is the MR. Good. So what do we see here? طبعا the image is not good, I agree. Okay, but this is
like
low parasternal,
4 chamber,
4 chamber, exactly. Low
4
parasternal
chamber.
a little bit, and we see the precardial fusion here. Okay,
Fusion,
this
yes.
is precardial fusion. By the way, when you see this one, this is fat. Okay, so don't be fooled into assuming this is a mass and stuff like that. This is fat, and when you have a fluid, the fat tends to be kind of impregnated with this fluid. It might stick out, it's stouter than it actually is, and it appears like this one. This is fat, this is epicardial fat, and this is fluid. Now, if we take the M mode here of the RV free wall, how could we describe it? Diastolic collapse, exactly. So diastolic collapse is a sign of
Ambulance.
Okay, good. Now, what do you see here? This one. Any guess? Does the heart look normal?
No.
What's
Typical
the
4
abnormal?
chamber, but the ventricle couldn't contract
By
well.
atrial dilatation.
Okay, one biatrial dilatation, right? What else? What about
There
the
is something
ventricles?
pushing out.
Oh yes, great.
Or on the right side.
Yes,
Right.
exactly.
Right ventricle.
Exactly, yes. You know that the LV and the RV are distorted geometrically. There is wasting at the base, so they become like wasting. There is a waste, okay? As if, like Dictora mentioned, كأنهم compressed from outside, but they are not compressed. This is advanced echo features of constriction. Yeah, when the constriction is advanced, you start to see this distorted geometry of the chamber, and they get wasted and elongated. So the LV, the RV gets elongated and compressed at the waist with this dilatation of the atria. طبعا in the echo it's very hard to assess the precardium and how thickened and calcified is, okay? Lakin this is the geometrical imprint of advanced constriction in echo. So if I see this image, I probably don't need a lot of hemodynamics because this is advanced constriction anatomy. Okay. Now, if you look at the septum here, do you appreciate any bounce? Sorry.
Septal bouncing.
Do you appreciate septal bounce?
No, no, no.
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 No. طيب why? Why we don't have septal bounce? Despite we have advanced anatomical features of constriction. Because of bilateral. الحاجة الثانية, by the way, bouncing is what? Bouncing is a respirophasic movement of the septum. Respirophasic means يعني مع inspiration and expiration. Now, what's the rate of respiration? The normal respiratory rate is what? The normal respiratory rate is 12, 14, right? 16. And the normal heart rate 60, 70. So the difference is that you need at least 5 beats to get a single respiratory cycle. So if you are not long enough in taking the loops, you might miss the bouncing, because the bouncing is not beat to beat. The bouncing is inspiration, expiration, the rate of which is much slower than the heart rate. That's why you have to be patient and take at least 5, even 10 beats to pick it up, and or else you might easily miss it. Okay? But remember, bouncing is not beat to beat. It's respirophasic. Now, what is this?
This is chamber.
Okay.
With color.
5 chamber with color.
5 chamber with color. Showing aortic regurgitation.
Okay. Can you give me your impression about how severe? Okay, great. Great. Yes, yes, exactly. Now, what is this here?
This is a continuous wave.
Okay.
Showing diastolic flow, the pressure half time around 278.
Very good.
It is moderate.
Okay. So now, by color, it looks wide jet occupying
more than
65% of the LVOT and forming a flow convergence, and it's going deep in the LV, so it's most likely severe. Now, when we look at, this is not for the same patient necessarily, but it might be for the same. I don't remember, is it for the same patient or not? I don't think it's for the same patient, but it's just showing the pressure half time of an AR jet. Now, pressure half time for an AR jet is 500, and 200, and in between. Okay? So 500 milliseconds, 200 milliseconds, and in between. If it's 200, that goes towards severe. This goes towards mild and in between. But you have to be cautious, by the way, and don't put heavy weight on the pressure half time. لأنه you might have severe and the pressure half time is 600. Okay? So the pressure half time does not reflect severity as much as it reflects the behavior of the LV to the AR jet. So it's not the function of the severity of the jet, but how the LV accepts and deals with this jet is the pressure half time. So if it takes the jet with high LV-EDP, that one is going to be short, and we are towards 200. But if it get accommodated and the LV-EDP is not so high, that will be high pressure half time or long pressure half time. That's why we tend to see this short pressure half time in acute severe AR and in severe decompensated AR. In severe decompensated. Okay? And it's a sign of decompensation. You might have severe compensated AR and the pressure half time is 500 above. But if it's decompensated because of elevated LV-EDP, then the pressure half time goes low. Or when it's acute, because in acute the LV has no yet chance to accommodate to this AR and the pressure goes high. Okay?
Yes.
Great. Now what do we see here? This is zoomed in of the aortic valve with color. So the aorta itself is not seen, but the color suggests what?
Mixed disease.
Mixed disease, exactly. Mixed disease. You're right. This one is flow acceleration systolic, suggestive of aortic stenosis, and we have a diastolic backward flow, which is AR. Now, this is abdominal aorta, and this is a flow of the abdominal aorta by PW. So what do you see? Abdominal aortic flow. This is what?
Diastolic reversal.
Yeah, that's the reversal here. But this reversal is not yet pan-diastolic. لأنه لو بقى ده pan-diastolic بيكون شكله كده. Okay? يكون بادي من هنا إلين all this occupying this كده. بيكون شكله كده. If it's pan-diastolic in the abdominal aorta, this is almost definitely severe. لكن حتى دي هنا, it's most likely this is severe aortic regurgitation because we have a diastolic flow reversal from abdominal aorta. When we have diastolic flow reversal from the descending aorta, descending thoracic aorta, and the flow is coming back, that is not necessarily severe. Not necessarily severe unless the flow is really high. فبيظهر شكله كده. طبعا in the abdominal aorta the forward flow in the thoracic aorta the forward flow goes this way and the reversal goes this way. That's why we see the forward flow below the baseline and the AR reversal above the baseline. Conversely, the abdominal aorta is exactly the opposite. Okay? The abdominal aorta is exactly the opposite because in abdominal aorta the flow is forwards toward the probe. That's why it's above the baseline, and the reversal goes back. That's why it's below the baseline. So remember this one. So this one here. When it is pan-diastolic, and when you do the TVI, so you trace it and you see that the TVI is more than 15, yes, that might be severe. لكن إذا بقى شكلها كده, يعني عندك forward flow like this, عندك diastolic like this. يعني هنا الآن this is not pan-diastolic reversal, and when you do the TVI you will find it 8, 7, something like that. So that does not mean we have severe AR. So remember this, diastolic reversal. Okay? Okay. Now this is again an AR. This is also AR. Okay. Now what is this here? What this one here? What is it?
This continuous wave.
Okay.
Across the aortic valve.
Very good.
Showing the velocity up to 112 millimeters, 6 almost.
Yes. So this is a gradient of high aortic stenosis. And just, yes, last word about aortic stenosis. The gradient, the mean gradient is by tracing the outer border of the jet this way, and you will get exactly. So you will get the mean, and the mean in this case might be like 65, something like that. So it is severe aortic stenosis. مرات الجت itself might be so يعني elusive لأنه أنت في الأبيكال 4 when you open the aorta it's like this, the aorta. So if the jet goes this way and you put your interrogation line, it might go this way. So the jet is going here. So there is an angle. Whenever there is an angle between your interrogation line and the actual jet line, معناته you are going to underestimate the velocity.
Yes.
And in this case, you have to search for other windows like right parasternal, suprasternal, and stuff like that. Okay. So don't give up. Don't give up. Whenever you are dealing with morphologically severe aortic stenosis, try to exhaust all the chances. Exactly. So I think we are gonna stop here, and we might take it from this slide later on. Okay.